Hello, everyone, and welcome back to our second session. We had a great first session, and we hope to continue. I'm going to start by introducing my co-moderator, Professor Lillian Cao, who you've heard speak and moderate in the first session. She's the current president of IFSO and the senior past president of IFSO Asia Pacific Chapter, and the senior past president of the Obesity Surgical Society of Australia and New Zealand. She's a senior consultant at the Flinders Medical Center and clinical associate professor at the University of South Australia. And she's obviously been involved in training multiple surgeons in bariatric surgery, both nationally and internationally. And I'm so glad to have her here as my co-moderator and co-director of the day.
Thank you, Reem. It is a pleasure. And hello, everyone, and welcome to session 2 of the World Health Digestive Day 2021. It is my privilege to co-moderate this session with Reem. She's the Associate Professor of Medicine at Weill Cornell Medical College and attending physician at the New York Presbyterian Hospital at the Weill Cornell Medical Center. She's also the Director of International Endoscopy with board certifications in gastroenterology and internal medicine in both the United States and the United Kingdom. So it's also my pleasure to welcome our esteemed panelists who have kindly joined us for this interesting session. Firstly, I'd like to welcome Samar Mata from the USA. He's a professor of surgery at Baylor College of Medicine, where he's also the chief of division of metabolic and bariatric surgery. He's the past president of the American Society of Metabolic and Bariatric Surgeons and past president of the Fellowship Council. Welcome, Samar. Next, I'd like to welcome Gerhard Prager from Austria. He's the professor at the Division of General Surgery at the Vienna Medical University in Austria. He's the former president of the Austrian Society for Obesity Surgery, and he's the current president of the European chapter of IFSO. Warm welcome to you, Gerhard. Next, I'd like to introduce Eamon Quigley from the USA, who's the chief of the Division of Gastroenterology and Hepatology at Houston Methodist Hospital, Texas. He's the past president of the American College of Gastroenterology and the World Gastroenterology Organization. Welcome.
Hello, everybody.
Last but not least, I'd like to welcome Kazuo Kasama from Japan. He's the director of the Weight Loss and Metabolic Surgery Center at Yatsusa Medical Cube in Tokyo. He's a clinical professor of Oita University in the School of Medicine and Department of Surgery. And he's the current president of the Asia Pacific chapter of IFSO and the immediate past president of APMBSS. Welcome, Kazuo.
Thank you for having me here.
And thank you. And now I'm going to introduce the speakers for this session. We have Dr. Ken Lo, who's a specialist upper gastrointestinal surgeon with an appointment at St. George's Public and Private Hospital, the Carina Private and Sutherland Public Hospital. He's performed over 3,000 surgeries and advanced laparoscopic surgeries, including primary and revisional bariatric operations. And currently he holds the position as an honorary treasurer of the Obesity Surgery Society of Australia and New Zealand, and is the secretary of IFSO Asian Pacific chapter. Thank you and welcome.
Thank you.
We welcome Dr. Caetano Marcassini. He is from Brazil and has been involved in endoscopy and laparoscopic surgery for many years. He brought the Intra-Gastric Balloon to Brazil in 1999, and in 2017 he performed an endoscopic sleeve gastroplasty. He's currently active in the area of general surgery and dedicated his time to obesity. Welcome. And following this, we have Professor Christopher Thompson, who is Director of Endoscopy at the Brigham and Women's Hospital, co-director of the Center for Weight Loss Management and Wellness. He's a Director of Advanced Endoscopy Fellowship Program as professor at the Harvard Medical School in Boston. We also have Professor Manuel Romero Gomez from the University of Seville in Spain. He's the chief of the digestive diseases at the Virgen del Rocío University Hospital and the head of the group for translational liver and research in the Institute of Biomedicine of Seville and Spanish Network. He's the leader of Sub-Project 7 for the European project Liver and Digestive, leader of the Litmus Project. And he's the coordinator of the European NAFLD registry funded by IFSO. And finally, last but not least, we have Dr. Olivia Ferreira, who is the vice chair of IFSO Integrated Health Committee. She holds a PhD and master's in human nutrition, and she's committed to broadening her investigative work in the field of nutrition related to bariatric surgery. She's a member of the ASMBS, IFSO, Bariatric Brazilian and Metabolic Society, and American Dietitians Association. So welcome. And Ken, if you can launch your first case, thank you.
Welcome to the first case study. My name is Ken Loy. I work in Sydney, St. George Hospital, and I'm a GI and bariatric surgeon. And I'm also current executive treasurer for IFSO APC. I have no conflict of interest regarding of this talk, and I speak for Resurfacing company as well. The first case today we have is Mrs. J.M., who's 50 years old lady, morbidly obese, BMI 51, weight 122 kilo, height 1.52 meters. She had various comorbidity, metabolic problem, including hypertension, high cholesterol, and she also type 2 diabetes, but also on insulin as well, and had diabetic history of more than 10 years. She also had reflux and a small hiatus hernia on gastroscopy, other disease including sleep apnea and arthritis and polycystic ovary syndrome. She was referred to public bariatric program, and based on decisions by our committee with MDT, we decided to perform Roux-en-Y gastric bypass plus repair hiatus hernia if possible. She lost some weight when we started pre-operative Opti-Fast for about 2-3 weeks, and her operative weight at the time was 115 kilo. Her blood test before showed iron deficiency anemia with hemoglobin of 110. Her creatinine is normal, 81. Her vitamin B12 is also quite low before surgery. Her liver function test showed mildly deranged AST, ALT, and albumin 34 as well. Her other liver panels, including hepatitis B and C, are negative. We performed preoperative ultrasound, which showed fatty liver with fibrotic changes, and subsequently performed fibrous scan, which showed early fibrous changes. Just a word of reminding how we're going to measure it, which could be explained by our gastroenterology colleague in the panel. That I think fibrous scan, the fibrosis score is regarding of how much pressure in the liver is measuring, and she's roughly around fibrous scan of about 2 to 3. Operation-wise, she had a Roux-en-Y gastric bypass, and due to metabolic problem, we decided to do a long BP limb and a short Roux limb, which bypassed total 1.6 meter of small bowel. Intraoperative finding, as picture has indicated, show fatty liver with some early cirrhotic changes despite Opti-Fast, but some weight loss enabled us to perform the surgery. She has difficulty with intubations as well, and also there was a difficult dissection with hiatus due to the space constraint and intra-abdominal access. The left lobe of the liver was quite solid and was difficult to retract with the nascence, which obscured some of the view of the hiatus. Nonetheless, we managed to perform hiatus hernia repair and the bypass successfully. There was some oozing from staple line. The stomach seems to be quite thick as well, but it was stopped by oversewing and also the buttressing as well with seam guard. Wedge liver biopsy performed for diagnostic purpose and comparison for the future as well. Her operations, the postoperative, in fact, was quite unremarkable, and she was discharged in day 4. And on 6-week follow-up, she already showed improvement in her liver function test, and she already lost some weight down to about 105 kilo. She's off oral diabetic medication and still on some insulin as well. And a wedge liver biopsy shows significant fatty liver with some early cirrhotic changes. So 6 months follow-up, her liver function test is nearly normalized, and her weight down to about 88 kilo, and repeat liver ultrasound show marked improvement of liver steatosis, and so as the results of the repeat fibrous scan as well. So I guess the question will be open to the panel in terms of our esteemed gastroenterologist colleagues regarding of what sort of investigation if we encounter these cases with fatty liver, and what sort of follow-up, probably more traditional, such suggestive, and also a surgical colleague in terms of whether there is any role of different type of operations applied to this case, and also a nutritionist, and see if 2 weeks of Opti-Fast is enough or not, and also our physicians as well in terms of managing the comorbidity. I'll open this discussion to the panel, and hopefully we can have some insight regarding of how to manage this type of patients. Thank you very much.
Thank you, Ken. And I'm now going to hand over to Lillian to launch the poll.
All right, we have a poll for the attendees. If you could use the dashboard on the right of your screen to answer this poll question, which operation do you think is the best for the treatment of fatty liver disease? There are 5 options here. We'll ask you to choose. While the audience is making up their minds of which is the best treatment, Ken, what is your operation of choice for fatty liver disease?
Look, I think whatever I'm speaking is probably not going to be right. I would defer the answer to my esteemed colleague, but I guess giving the experience from the last sessions, I think it's really opened our eyes when we are collecting our data regarding of obesity as a disease, comparing to COVID even, because COVID disease is only hopefully short term, but this is a ongoing things that is going to consume ourselves. And I think it doesn't matter about operation like Rahul. I think the most important things is when to operate and how we're going to operate without causing long-term or short-term problem. I suspect traditionally Roux-en-Y gastric bypass is what we're trying to do for metabolic disease, but a lot of the other surgical options has opened up the doors on potentially more powerful interventions, according to my surgical colleague. But I guess with power come responsibility, and I think there will be more nutritional issue that we may encounter as well. So I guess that's why we are here for. So I'd rather listen to our expert instead.
All right, before we do that, let's see what the attendees say. Have we got the answers to the poll? We should have any moment now the answers.
Before the answer, I guess I have to throw in a little bit of our Asian Pacific things. I think as you've seen, there's going to be a lot of patients that we have to deal with. And I think we got to plan for the futures, and our criteria, according to Kasama's and all of us looking at our Asian, is slightly different than Caucasians, but we can draw on their experience and see what happened.
Well, looking at the poll, 45% of the attendees believe that the Roux-en-Y gastric bypass is the best treatment for fatty liver disease. So I think we will ask the opinion from our speakers. So I'm going to start off by asking the bariatric surgeon to tell us about this presentation. So I'm going to invite Professor Citano Marcassini for his presentation and his comments.
Yes. Hello, guys. I have a presentation recorded, but the thing is about when doing the surgery, this is a good question. And what surgery depends on basically on what the liver looks like during the surgery, and the biopsy and the pre-op exams will show us. So I think we can show my recording lecture, please. Could we start?
Hello, guys. My name is Caetano Marquezini. I'm a Brazilian surgeon and been doing bariatric surgery for the last 27 years. These are my disclosures. I guarantee any of them will interfere in my lecture. Well, first things first. This is angulation, something I've been doing for the last 20 years. And this 45 angle position modifies consistently the fat and visceral arrangement inside the abdomen, improves the visual angle of the optics, and shortens the distance between the trocar entrance and the camera and the hiatus. Liver retractors are very important during the laparoscopic procedures and usually requires an additional trocar and subxiphoid incision, increasing risk of wound complications and postoperative pain. And the use of traditional mechanical liver retractors had been associated with transient increase in liver transaminases and risk of iatrogenic liver injury. And there are a lot of proposals published. I advise a lot of surgeons to take a look at these papers. In patients undergoing surgery, the prevalence of an FLD is 62%. 1/3 of these patients already have fibrosis. 9 to 20% will progress to cirrhosis. Cirrhosis will be diagnosed, incidentally, in 4% of surgeries. Bariatric surgery impacts on NFLD in 88% of improvement and leads to 30% of improvement in fibrosis. Gold standard diagnosis is liver biopsy, which is important to calculate an LFD activity score. And interestingly, there was no statistical difference in improvement after sleeve gastrectomy and Roux-en-Y gastric bypass. But we do know that surgeons usually favor sleeve gastrectomy over Roux-en-Y gastric bypass. And this is because there's a potential risk of hepatic decompensation after malabsorptive procedures, a difficulty access of the bypass stomach and bile duct, and the altered anatomy with Roux-en-Y gastric bypass may make future liver transplantation more difficult. The biggest hindrance to preoperative counseling of patients about the risk of the surgery is that the majority of cases of cirrhosis are diagnosed incidentally during the surgery by visual inspection of a nodular liver. Routine intraoperative liver biopsy should be offered to all patients undergoing surgery. Liver stiffness measurement can be reliably and predict the presence of advanced fibrosis preoperatively with a sensitivity of 80% and specificity of 85%. Early postoperative liver decompensation may happen in 7% of the patients, which should be managed conservatively. And Roux-en-Y gastric bypass should not be a contraindication, being reserved for situations where sleeve gastrectomy is not possible as Barrett's esophagus or severe GERD. In cirrhotic patients, portal hypertension is a relative contraindication of the surgery. And the surgery may ameliorate comorbidities as type 2 diabetes, hypertension, dyslipidemia, but will probably not show any improvement in cirrhotic liver fibrosis. In these patients with a compensating disease, the mortality is 0.9%, but it can increase to 17% in patients with decompensated cirrhosis. There's a limited data on outcomes on bariatric surgery in cirrhotic patients, but in cases with advanced liver disease and severe portal hypertension, it has been advised to do the TIPS procedure prior to the surgery. And finally, patients with ultrasound-proven steatosis and ALT level above 53 should undergo intraoperative liver biopsy because there's a high probability of NASH. Thank you very much. These are my considerations, and I will be here for you guys to discuss and talk about what I have stated. Thank you very much.
Thank you, Caetano. I think we'll move on. I'm going to invite Chris Thompson to give his views as an endoscopist. Thank you, Chris.
I'm Dr. Christopher Thompson from Boston, and I've been asked to speak on the treatment of NAFLD and NASH from the endoscopic perspective. Here are my disclosures. To refresh our memories, fibrosis stage is the strongest predictor of liver-related outcomes The mainstay of treatment of NASH is weight loss, with 7% total weight loss being associated with improvement of steatosis and inflammation, and 10% total weight loss required for regression of fibrosis. So the main questions that need to be answered are, can EBMTs achieve a 7 to 10% total weight loss, and is there any evidence for improvement in liver inflammation or fibrosis with these procedures? EBMTs can be broadly classified into two categories: gastric devices such as balloons, suturing platforms, and aspiration therapy, which primarily focus on weight loss, and small bowel devices such as sleeves and duodenal and mucosal resurfacing, and anastomotic devices which have more direct metabolic effects. We will start with intragastric balloons, and there's several types. There are fluid-filled balloons, there's gas-filled balloons, there's adjustable balloons, and procedureless balloons as well. They all have fairly similar weight loss outcomes, so we'll focus on fluid-filled balloons and a meta-analysis of 17 studies in over 1,600 patients that showed a total weight loss of 11% at 12 months. This was really across all relevant BMIs. This was a case report from our group looking at a 29-year-old female with Down syndrome and various serious medical conditions. She was 181 pounds, 4 foot 10 inches tall, and a BMI of 37.8 with NASH. And the initial liver biopsy is seen here with grade 2 steatohepatitis and stage 1 fibrosis. She underwent a 6-month balloon placement, and at removal, her weight was now 110 pounds with a percent total weight loss of 39.2 and a BMI of 23. And the EUS guided liver biopsy performed at the time of balloon removal was seen here with a complete resolution of steatohepatitis and no significant fibrosis. We also have a prospective series of 21 patients looking at early stage liver fibrosis and intragastric balloon treatment. You can see at 6 months when the balloon was removed, there was a 11.7% total weight loss. And here are all of our liver outcomes. There's a 3-point median decrease in NAS. Fibrosis improved by 1.17 stages. MRE detected fibrosis improved by 1.5 stages. And it was a quite encouraging study. However, percent total body weight loss did not seem to correlate with reduction in NAS or fibrosis. Moving on to gastric remodeling and endoscopic sleeve gastroplasty. And you can see here we're trying to really recreate a gastric imbrication procedure endoluminally with a series of running and interrupted stitches. So here's a meta-analysis looking at 8 studies in over 1,700 patients, which shows a 16.5% total weight loss at 1 year and a 2.2% adverse event rate. What about metabolic outcomes? We have a prospective registry from Reem Shariah's group looking at 118 patients, and they all underwent ESG for NAFLD. Main outcomes here are hepatic steatosis index and NAFLD fibrosis score. In 2 years, we have a 15.5% total weight loss, and you can see the HSI score decreased by 4 points per year, and the NAFLD fibrosis score decreased by 0.3 points per year. So very encouraging. And here we have 24 patients showing an improvement in risk of hepatic fibrosis, decrease from an F3-4 or indeterminate down to a F0, F2, and only 1% of patients experiencing an increase in that risk. Duodenal and mucosal resurfacing also shows some promising results in a multi-center single-arm study of 47 patients, which showed improvement in HbA1c, fasting blood glucose, ALT, and AST, but very interestingly, they showed a 30% lowering of relative fat and a 6% reduction of absolute fat on MR hepatic fat. And finally, we have a meta-analysis looking at all EBMTs and their effect on metabolic comorbidities. 18 studies, over 800 patients, 14.5% total weight loss at 6 months. And you can see here the primary outcome is liver fibrosis, 4 studies, 162 patients. And the fibrosis was reduced. Here you see the standard mean difference by 0.7. And the secondary outcomes, including ALT and histologic NAFLD activity score, were all significantly improved as well, although the grade was low to very low for quality of evidence. In conclusion, EBMTs do achieve 7 to 10% total weight loss, and early evidence suggests that they may offer a promising alternative for the treatment of NAFLD and NASH. And I believe combination therapies and personalized treatment programs are now the keys to future success. Thank you.
Thank you, Chris. I think we'll move on. We'll hear from the hepatologists. I'm going to invite Dr. Manuel Gomez to give his comments. Thank you, Manuel.
Hello, everybody. It's a great pleasure for me to be part of this World Digestive Health Day, and thank Professor Macedo for inviting me to this very interesting panel. Today we are discussing the case by Professor Loy, and I'm giving my opinion as hepatologist in this patient with morbid obesity and NAFLD. This is my disclosures. And our female, in summary, Mrs. J.M. is female, 50 years old with comorbidities, including diabetes, arterial hypertension, hyperlipidemia, sleep apnea, and because with morbid obesity, 53 kilo per meter square as body mass index. That means morbid obesity. Our patient showed a quiet fibroscan with 249 decibelius per meter in the cap. That means in the limit of steatosis, but in the ultrasonography, you can see how the liver is hyperechogenic in comparison with the kidney. And on the other side, fibroscan was 6.8 kilopascal. That means it's a quite relaxed fibroscan, usually associated with non-advanced fibrosis because lower than 8 kilopascal. But it was a surprise when we calculate the epimetriosis score and was 0.84. That means highly risk of advanced fibrosis, and FIB4 was 3.19, also linked to advanced fibrosis. Is Mrs. J.M. suffering from an NAFLD-associated advanced fibrosis with this fibroscan and this non-invasive method? I think so. In this study by Professor Ampuero, demonstrate how the interpretation of the kilopascal of the fibroscan depends on the metabolic alteration in the liver. When the epimethylfibrosis score is higher than 0.47, a fibroscan lower than 14.3 kilopascals or a fibroscan higher than 6.2 kilopascal demonstrate a risk of that significant fibrosis in approximately 3/4 of the patient, advanced fibrosis F3, F4 in a half of them, and cirrhosis in 8 to 10%. That means our patient seems to be at risk of advanced fibrosis. And please, surgeon, do not forget a liver biopsy during the surgery if doing bariatric surgery. We need to keep in mind what can we do in this patient with NAFLD at risk of advanced fibrosis and morbid obesity. The key point is try to promote weight loss. If our patient lose 10% of the body weight, we can improve steatosis 100%, promote fibrosis regression 80%, and NAS resolution 90%. That means that in the 10% of patients undergoing this lifestyle intervention, we achieve a weight loss of 10%. That means 90% fail to reach this goal. This is the main reason by which we need to move from the diet and physical activity to the use of drugs. In the drugs, we can use semaglutide, naltrexone, bupropion, or orlistat. This drug able to promote weight loss when we analyze what is happening in the liver in the second liver biopsy at 24, 36, or 48, or 52 weeks, irrespectively of lifestyle intervention versus, for example, orlistat. The improvement in the NAS score, steatosis, ballooning, and lobular inflammation was comparable and quite similar. Semaglutide is a GLP-1 agonist able to promote improvement in the liver. In this clinical trial published in New England last year, semaglutide in the high dose demonstrated that NAS resolution in 60% of the patient is a very high rate, but also the semaglutide high dose was linked to body weight reduction of 12.5%. That means we can be absolutely confident that this drug is able to promote weight loss, and this weight loss was associated with improvement in the liver, in with steatohepatitis resolution, and also with the rest of the parameters. Just in our patient, we should confirm advanced fibrosis in every patient. We need to implement lifestyle intervention. It doesn't work drug therapy. It doesn't work endoscopy and bariatric surgery, because we need to promote weight loss. Semaglutide therapy emerged as a first-line therapy to promote weight loss in patients with not only a risk of advanced fibrosis. This is my part, and now the patient require more advanced therapy, including endoscopy and bariatric surgery. Thank you for your attention. Many thanks to my team in Virgen del Rocío University Hospital, the Department of Disease, and also the Celiber Group in the Institute of Biomedicine of Seville. Thank you very much for your attention.
Thank you very much. And I'd like to now welcome Sylvia to talk about the nutritional aspect of this case.
I would like to thank IFSO and the WGO for the invitation. I'm glad to be here, and I'm going to make some comments about Dr. Kinloy's presentation about a patient with non-alcoholic fatty liver disease. I have nothing to disclose. And as we know, non-alcoholic fatty liver disease is the most prevalent form of chronic liver disease in the world. It affects near 15 to 35% of global population, and it is more prevalent among patients seeking bariatric surgery. We also know that a modest weight loss, near 5 to 10%, is known to decrease intra and postoperative complications, such as hypertensive crisis, diabetes, thromboembolism, sleep apnea, and principally hepatomegaly. And we know that decreasing the liver size, it may contribute to a reduction of surgery time. This chart we can see, it is a randomized trial conducted by our team, and we saw that patients that had presented weight loss before surgery, they presented also a reduction in surgery time. So when we talk about weight loss before surgery, most of the time we use a very low calorie diet that is an energy restriction that goes up to 800 calories per day. Dr. Kinloy used the Opti-Fast, that is a commercial brand of a liquid, very low calorie diet. We know that these diets, when they are used in an adequate way, with an adequate amount of protein, carbohydrates, vitamins, and minerals, they will have patients to present a rapid weight loss. They will decrease visceral fat, they will present reduction of liver size, and they will keep their vital healing capacity with just few side effects. Dr. Kim and his team used this diet for 2 weeks, and the patient presented a good weight loss, near 5%. She presented the 2 nutrition deficiencies. They were treated before surgery. Despite the good weight loss that the patient presented before surgery, during the surgery, they saw that she had enlarged liver. And it happened probably due to the advanced stage of cirrhosis that she presented. However, with 6 months, the patient presented a good amount of weight loss. She had lost 27 kilograms, and she have shown an improvement in the degree of fibrosis, showing that the non-alcoholic fatty liver disease was treated with the adequate amount of weight loss that she presented after surgery. And some recent guidelines, they have shown that even when the patient presents some histological manifestations of liver injury, they can take advantage from the bariatric surgery, and they can get better from their fibrosis with the weight loss, using bariatric surgery as a tool for weight loss. I would like to highlight 3 important points as a conclusion. First, that there was a concern about weight loss before surgery. Dr. Loy's patient present the BMI higher than 50, this population, they need to lose a little bit of weight because it will contribute to the decrease of surgery time. So it is important to highlight that losing weight before surgery is an important treatment. Second, there was a concern about nutritional screening. There was this concern and the patient was treated. And it is important to highlight that this population, they present at least one nutritional deficiency before surgery. So I was happy that Dr. Kinloy and his team had this treatment before surgery. And third, that bariatric surgery is, and in this case was effective in treating non-alcoholic fatty liver disease. Thank you.
Thank you very much, Dr. Sylvia Ferreira. And now, before we start our discussion with our esteemed panel and speakers, we'd like to relaunch the poll that you heard at the beginning of session 2. Many of our audience members have changed their mind. So the question was, which operation do you think is the best for the treatment of fatty liver disease? And the answers are sleeve gastrectomy, Roux-en-Y gastric bypass, single anastomosis gastric bypass, single anastomosis duodenal bypass, and the endoscopic sleeve gastroplasty. Just to be controversial, Samer, I might ask you as the first question while we're waiting for the poll to launch and answer. Do you think there's any one right answer in this, or is it just weight loss?
Well, the right answer is to do what's right for the patient, obviously. So you need to study your patient carefully, know what their comorbidities are, and whatever other conditions they might have. I was a little surprised, and this is no criticism of my friend, Dr. Loy, but in a patient who has a history of anemia and who has arthritis, who might be requiring NSAIDs, who knows, might be smoking, I would favor a sleeve gastrectomy, especially in patients who have liver disease, because there's always the possibility that they may need a liver transplant in the future, and you want to maintain that endoscopic access to their biliary system. But the only right answer I can say is to do what's right for that particular patient.
I agree. I feel like a lot of patients come in with the preconceived idea of what they want, and here are the answers. Do you want to comment on these, sort of the before and after?
So we can see here a small shift of respondents from gastric bypass towards the sleeve. I think maybe based on understanding the progression of fatty liver disease and that it could lead to liver failure or liver transplant. And some of these patients are very ill, especially if they're very heavy. So I can see the sleeve gastrectomy as an operation that might result in resolution of comorbidities that are equivalent to a large degree with Roux-en-Y gastric bypass. That's what I see here. And it's interesting that also Dr. Thompson's lecture has influenced the respondents. As you can see, there's been a rise in the number of respondents advocating endoscopic therapy.
Perhaps I can sort of echo on Samai. I agree. It was actually a really struggle on which operation we decide to do and tossing around all the risk factors. But yeah, we don't have the crystal ball. We try to do what the best for the patients, and essentially weight loss will be the best. But procedure-wise, it is hard to choose. And I think there'll be a different answer for if we ask everyone, I think.
Absolutely.
Reem, Lillian, can I ask a question?
Definitely.
Yes, absolutely.
Sure. I just, first of all, my disclosure is that I'm not a hepatologist and I'm not directly involved in obesity, but I'm very honored to be here. But just listening to the wonderful case that was presented, I had a couple of questions. Based on our previous session when we spoke about cancer and the fact that this patient had iron deficiency anemia, preoperatively, I just wondered if consideration was given to upper endoscopy and perhaps colonoscopy before proceeding to surgery because of the risks. And the other question I had is in terms of the liver disease, how far you would go in terms of assessing for portal hypertension, given that you were also going to perform anti-reflux surgery, and whether, for example, you would do endoscopy looking for varices.
I think we did do gastroscopy, and colonoscopy has been excluded in terms of gastric colon cancer, etc. And I guess partly to assess for the reflux and Barrett's and hiatus hernia, and that's why we decided also to repair it, because there are studies that pointed out even despite Roux-en-Y gastric bypass seems to be the treatment for reflux surgery, you still have to attend to hiatus if possible. And the liver disease do increase the difficulties of accessing the hiatus due to space constraint, but we managed to repair that, and the reflux was moderately or markedly better together with the weight loss as well. I guess I shouldn't speak. I think I speak too much, and I should leave some of the space for my esteemed panel to comment on that.
I'd like to ask a question to our other surgeon in the panel. Gerhard Prager, what is your preferred operation?
I think there is no deep preferred operation. I think all these operations that lead to markedly weight loss will also improve NAFLD. NASH improvement is, of course, much more difficult to achieve. But I just want to mention a word of caution. If we exclude larger amounts of small bowel, there might be, let's call it, too much of a good thing. I give an example. When we had a look at our one anastomosis gastric bypass series, excluding at least 1.5 meter, we see in the first year an transient elevation of liver enzymes, which comes after 1 year to normal. But if you go further and exclude even more, you see also, or you can see, a deterioration of the liver function. This means we should be cautious to exclude bigger amounts of small bowel in patients with advanced stages of fibrosis. Saying that, I fully agree that sleeve gastrectomy and Roux-en-Y gastric bypass with a rather short BP limb are the procedures of choice in patients with advanced liver fibrosis. For those with even cirrhosis, I just want to mention that doing a sleeve gastrectomy, you change the portal blood flow, and this might contribute to an elevated percentage of portal vein thrombosis in patients with sleeve gastrectomy, just to give you a little bit food for the brain.
And to add to that, Dr. Quigley's question, if we get referred patients who have an established diagnosis of cirrhosis, then we typically do look for portal hypertension, because that is a very high risk factor. Patients can essentially exsanguinate on the table. So we do a CT scan, or we do interventional radiology will help us out. And if they do have portal hypertension, then we might apply tips, a shunt, to try and reduce their overall mean gradient. This has its own side effects, of course. These are a very high risk category of patients that we treat very carefully and optimize very carefully before considering surgery. But after all, surgery is their only resort, because that's the only way they're going to get a liver transplantation.
I just want to mention that it is very difficult to identify preoperatively those patients with very advanced NASH. FibroScan in our hands was not especially successful in the morbidly obese patients, although we were using the X-large probe. So this is still something we are struggling with, at least in our institution.
I agree.
One thing we do in our institution is a very thorough GI evaluation, obviously even for the surgical patients, but Something that's very useful is endoscopic ultrasound to look at the liver, but then also to do liver biopsies and direct portal pressure measurements. It's minimally invasive, and it's really a great way to assess risk in these patients.
Yes, to add a comment, I would like to highlight that in cirrhotic patient or in patient with NASH and advanced fibrosis, the main aim, the goal is to lose 10% of body weight. That means we need to be conservative when selecting the method to achieve this goal, and we don't need to lose many kilos. No? And it could be very important because we can balance both the risk and the benefit when managing this patient, in which I looking from the liver, no, as a liver-centric point of view. I'm just concerned about that. And just adding a comment to a previous discussion about how can we consider obesity, no, if a disease or a symptom. From my point of view, obesity is just a condition. It's like alcoholism. And this is the key point we need to address, thinking separately. We have two problems, obesity and the liver disease. And separately, we need to address it in different manners.
So if I may, I have a question I've been meaning to ask you, Dr. Gomez. I agree that reaching 10% weight loss is very beneficial for these patients. It reverses a lot of the problems of the liver. The problem is, though, maintaining that weight loss. You know, I have yet to see a paper that has a long-term effect of lifestyle. And medications work, like your GLP-1 agonists, but they're expensive, and the patient would have to take them for the rest of their lives. As for endoscopy too, many of the procedures tend to be temporary, whether it's balloons or sleeves. And so, you know, what are we left with that has a long-term beneficial effect? And frankly, I am biased because I'm a surgeon, but I think the truth is that for now, surgery is the most effective long-term therapy for these patients.
I fully agree. This is the most difficult challenge at this time. How can we address that? Because regain is very common. More than a half of patients in very short period of time, at 5 years, is very common. This is an option to promote endoscopy or bariatric surgery, because the patient need some help beyond the lifestyle intervention, even beyond the drugs. But we need to try to develop a multidisciplinary approach, trying to have, for example, to have the liver recovery in the hospital, as we can recover the heart of the kidney or the lung. I think we need to work together with nutritionists for sure, with the surgeon, hepatologists, and all of us trying to improve the health of the people. That for sure it's strongly related with weight loss, but we need to promote weight loss and to keep. And just a major problem that I think we have in clinical practice now is the management of obesity pre-transplant patient. Cirrhotic patient with morbid obesity that require a liver transplantation. What are we doing? And at this time, we can start a therapy in a very short period of time, 3 to 6 months. For example, a patient with liver function okay and a liver cancer, we can try to promote weight loss in 3 to 6 months. But for sure, we need to keep in mind that after the transplant, we need to keep the patient in this weight, and this
or else they lose their transplant.
For sure, this is the same problem that we need to address. Is how are we prolonging over the time all our activity to keep the patient safe and healthy.
If I may interject something here. So I think it's risk and benefit, right? We heard that with gastric bypass and advanced liver disease, you have substantial risks there. I agree with balloons. I mean, there's lower risk, but if there's no benefit, it's also not worth doing it, right? So ESG, however, does have very solid data for 5-year outcomes and maintaining a 15% total weight loss. So that's great. And now if you combine, and Dr. Sharaya's data is really one of the best there. Now, if you combine that with medicines, we might be able to really get a long runway with this while minimizing risk. So I think that we should not say surgery is the only answer here. I think we have to look at endoscopy as a very good solution for many of these patients because it allows us to limit risk and does get us stably above that 10%, but it's not balloons or necessarily some of the other therapies. The other thing that is interesting is duodenal and mucosal resurfacing. Now, this gets back to something Francesco Rubino was talking about. We do not see 10% total weight loss with that at all, not remotely, right? But they were getting really impressive results with reversal of liver fibrosis and fat improvement. So something very interesting there is another mechanism of action unrelated to weight loss. So I think we have a lot of learning to do. And I do think there's, surgery is certainly a wonderful option for many of these patients. But I do think we also have to be very open-minded about these endoscopic alternatives.
Great. If I may just make an intervention here, it's important to notice that liver disease is not the only thing that occurs in these patients. These are very obese patients. They usually have diabetes, they usually have hypertension, they usually have a lot of other diseases that I'm an endoscopist. I really believe it's a new method and it's coming for something different in the future. But for now, for these patients that there are a complex unity of diseases, I still think surgery is the best solution for these patients because we can see not improvement only in liver fibrosis, but in the rest of the comorbidities.
Yeah, I think we may not agree on the answer here, or we would just have a long, lengthy debate, but I'm glad and the risks and benefits of each type of procedure. Sylvia, there's a question for you from the audience. What do you comment on the keto diet for obesity and for diabetes? And if you suggest the keto diet, how long do you suggest patients to be on it?
As a strategy for preoperative weight loss, we used to use more very low calorie diets. That's Dr. Kim used it, Opti-Fast, that has a right content of carbohydrates, protein, and lipids. Keto diet can be used in general population like obesity. My concern is with the adherence of a keto diet for a long term. So maybe for 3 to 6 months, it can be a strategy. Or if you have a patient that is losing weight and you need to change the strategy, sometimes keto diet should be a strategy. However, as it doesn't have a lot of carbohydrates or nothing of carbohydrates, the adherence is a challenge. So maybe listen to your patient, and knowing the adherence and the weight loss is a good way to know if it is going to be effective.
Thank you. And do you recommend the Opti-Fast diet for everyone pre-op, or is this something that you would also recommend for people sort of after surgery they've had, or after endoscopy, they've had a little bit of weight gain in order to maintain their weight loss?
Opti-Fast is a commercial brand of a liquid diet. And I have studied a liquid diet before surgery, and it's a good strategy if you use like from 2 to 12 weeks. However, 12 weeks I think is like too long. 2 weeks is enough because most of the weight patients lose in the first 2 weeks. And the adherence is better than when they eat normal food because there is less options, and it is easier to measure a cup of whey protein or a plate of a soup. And when you use a brand such as Opti-Fast or whatever, you know the content it is easy to know the content of the food. So I think it is a good strategy when you want rapid weight loss and with a security like before surgery, you need to improve the nutritional issues. You should promote good wound healing. So I think it is a good strategy. Here in Brazil, we don't have this brand available, but we have other brands. And you can do a liquid diet even with real food like soups, whey protein, and yogurts, and things like that.
I have a question for Kazu. If in the Asian population, we know that obesity, lower rate of obesity is associated with the comorbidities of the metabolic disorders. Do you find that fatty liver disease is also more prevalent at a lower BMI in the Asian population?
Yes, that's true. So from the viewpoint of Asian Pacific chapter, I'd like to emphasize that NASH, the biopsy-proven NASH, is much higher in Asian population. Like my series of biopsy, 74% of my patients BMI over 35 had NASH. Also in Taiwan, 72% of the patient, the bariatric patient, had NASH. But in Australia, just around 30 to 40% of the bariatric patient have NASH proven by biopsy. So that the Asian population has much higher risk of NAFLD. And recently, Asian Pacific Association of the Study of Liver Diseases just published their clinical guideline for NASH. They tried to change the name from NAFLD to MAFLD, metabolic disorder associated liver diseases. So that, and also they made a guideline to indicate the bariatric surgery for BMI over 35 with NASH, with MAFLD. And also for Asian population, BMI over 30 with MAFLD should be considered bariatric surgery. So that in the Asian Pacific region, the view is a little bit changing now. And also that the important thing is the follow-up of the Ken Loy's patient, because I also have the same kind of patient, and he lose more than 35 kilogram, and also all kind of comorbidity resolved. And also the CT scan revealed that NASH and the NAFLD had a resolution at 2 years after surgery. But he developed HCC at 7 years after surgery, because the patient still have some fibrosis after surgery. So such kind of patient must have some kind of follow-up, like sonography every year or something like that. That's my point of view.
Thank you. From the attendees, there's a question for Chris Thompson. Is there any experience about combining intragastric balloons and ESG for better weight control?
Yeah, not so far. That would be a sequential thing that would have to be done. We know that balloons are contraindicated in any stomach that has had any type of surgery, whether it's anti-reflux surgery, prior bariatric surgery, et cetera. So it's important not to do them, in close proximity. And I would probably say you would start with a balloon and then sequentially follow that with an ESG in planning a study. But I'm not aware of any data using that approach yet. More likely, you're going to see combinations of ESG with a small bowel procedure, such as an ESG with mucosal resurfacing or ESG with a endobarrier type device or maybe a magnetic anastomosis. Or medications, right? Semaglutide, that'd be a really great combination that Vivek Kambari had studied a little bit with some Brazilian colleagues that seemed very compelling.
So I think with the diagnosis of a fatty liver or NASH or NAFLD, liver biopsies is still considered the gold standard. But as surgeons, we don't always do a liver biopsy. I like the opinion of the other surgeons. Do they do liver biopsies regularly or only when they're asked by the hepatologist or the gastroenterologist?
Yeah, this is Samer. And in the early phases of my career, I used to routinely do liver biopsies on all our patients. In fact, all my partners did as well. And then we found that the information that we had from these biopsies really didn't inform us in the course of the patient or its prognosis. So we stopped doing them unless it was indicated or in specially selected patients. But now that I'm, my interest in this disease is rising again, I think I will go back to routinely doing liver biopsies. It takes only, you use the true cut needle, it takes only 5 minutes. And although it's not a totally benign procedure, it is rather safe as long as you do it properly. So the answer is, I'm going to go back to doing routine liver biopsies, yes.
How about you, Gerhard Prager?
I do it routinely in all my patients, I think, for the last 10 years. And I find it very useful.
Citano?
Well, here we have to, talk to the insurance payers about what we are going to do prior to surgery. So we have to justify the motive. So no, we don't do it routinely. But when I get any visual intraoperative modification of the liver, I do the biopsy because I cannot get out without getting the diagnosis I need. So then I justify what I'm doing to the payers. This is the only problem. And some exams we do, and a lot of things we are talking about preoperatively. I know there's a lot of countries that the insurance payers they do not pay for these exams. They do not. They require a lot of paper doing, and usually they do not let us to do these exams, including endoscopy. Chris, I know here in Brazil we do it routinely, but I know there's a lot of countries that it's not justifiable for the payer. So this is important also to talk to who's listening to us, that we have to go for what we have on our hands.
Lillian, just a comment?
Yes, definitely.
I'm more than happy listening that you are doing or planning to do routinely, because as we learned from the biochemistry, that ALT-AST, normal ALT-AST is very common in patients with NAFLD, and we need to use non-invasive tests like FIB4, etc. When you are looking at the surface of the liver, it's much better to have a liver biopsy, because many times you can find a future that you are not can anticipate when you are doing the surgery, And I think it's very important to stratify and to quantify exactly what is happening in the liver to improve the management of this patient. And at this time, liver biopsy is crucial because, as we discussed before, non-invasive tests like FibroScan, the XL probe, they are not enough diagnosis accuracy for the decision making, and we need to combine. For sure, we need to develop an algorithm, a diagnostic algorithm, to be absolutely confident with the stage of fibrosis and the presence of steatohepatitis. But in the meantime, we need to use the liver biopsy of gold standard, and surgery is a fantastic moment to have this information.
What about Japan, Kazu? Do you do liver biopsies?
I used to do a liver biopsy in a clinical study setting, but recently I don't. Actually, that it's very rare to have a chance of a second biopsy for the patient after bariatric surgery, so that we couldn't reveal that the improvement of liver disease by second biopsy. But yeah, as many here suggest that it's very useful to do a routine biopsy, so that we will talk with our colleague to do that.
Okay, Reem, have you got any other questions to ask our panel?
No, I was going to ask the same thing to Chris, if he routinely does either FibroScan or liver biopsies, or we're more increasingly doing so because of the availability of portal hypertension testing now endoscopically.
Yes, we'll do a FibroScan on all patients, revisions or primaries, and then depending on what we see on the FibroScan, we will do an endoscopic ultrasound with liver biopsy and portal pressure measurements. And I think it's very nice to do. We don't do that as part of the actual weight loss procedure. We do that in advance. That way we're catching some people with portal hypertension, and we can address that with beta blockers and proper preparation before our procedure.
If I may mention something, please. one thing I'd like to suggest or even recommend to the group and other clinicians is what we've done here at our institution in Baylor. We've actually started a fatty liver clinic. And it's a clinic where patients who have fatty liver disease, many of them are obese. We approach them in a multidisciplinary fashion with the hepatologist. We actually have designed a special educational seminar for these patients. And we work together to both evaluate, optimize, and then treat these patients. And the beauty of it is that they continue to be followed in this specialized clinic. And with the rising number of these cases, I think there's a lot of benefit in that, but just a suggestion for the group.
I totally agree.
We do the same thing. I think that's sort of the future, are these multidisciplinary clinics between all prongs of what we see here in the case presentation, all disciplines to be part of it.